Good afternoon, and on behalf of the Bipartisan Policy Center, I'd like to welcome you to today's event on the state of the COVID-19 pandemic. My name is Dr. Anand Parekh, and I serve as BPC's Chief Medical Advisor. While many Americans have resumed their normal summer activities, albeit not exactly the way they did pre-pandemic, the country is still not quite through this pandemic, as new variants like BA.5 continue to arise and vaccination campaigns need renewed energy. Today, we'll hear from federal, state, and philanthropic leaders about where we are in this pandemic and where we should expect to be over the coming months. First, BPC Senior Vice President of Communications, Steve Scully, will engage in a fireside chat with Dr. Richard Besser, President and CEO of the Robert Wood Johnson Foundation, to discuss his thoughts on the pandemic, lessons learned, and the Foundation's focus on health equity. Next, we'll hear from Dr. Ashish Jha, the White House Coronavirus Response Coordinator, on his assessment of the state of the pandemic and the administration's current priorities. Finally, we'll be joined by two state health officials, Dr. Natasha Bagdasarian of Michigan and Dr. Kathleen Toomey of Georgia, to learn about the pandemic response from the front lines in their respective states. If you have any questions for the speakers today, please tweet them to hashtag BPC Live or enter them into the chat, and we'll try to get to as many as we can. With that, I'll now turn it over to Steve and Dr. Rich Besser. Steve?
Dr. Besser, on behalf of the Bipartisan Policy Center, thank you for being with us in this conversation. And I want to begin at a very broad level. We're 2.5 years into this pandemic. So where are we today in the summer of 2022?
You know, Steve, I think that how you answer that question depends on whose perspective you're taking. If you look at this from a broad global perspective, we still see situations of incredible inequity, where some countries have more vaccines than they currently want to use, and some countries do not and have not been able to get vaccines out to large proportions of populations who would clearly benefit. We're in a situation where we continue to see new variants of COVID emerging at rates that I don't think anyone expected. But we're also in a situation where I think something miraculous has happened, where faster than we've ever seen for any public health crisis, we have so many vaccines available to address that. At the beginning of this pandemic, I don't think anyone thought that within a year we would have 2, 3, 4 effective, safe, highly effective vaccines against a new infectious agent. I truly thought that we would be using the most severe public health measures for much longer periods of time. And that has allowed us to do a couple things. It's allowed us to save incredible numbers of lives. Which is always what you want to do when there's a new public health crisis. It's also, though, allowed many people, I think, to become complacent and reach a position where COVID is no longer something that raises much concern. I think we need to find a middle ground there, because there are many people who remain at significantly higher risk of having severe COVID and unfortunately dying from COVID. And we need to make sure that as we go about our lives, as we get back to a more expected and hoped for sense of normal, we're ensuring that those people who are at greatest risk have what they need to protect themselves, and we're not unduly putting people in danger.
So let me follow up on your earlier point, and we'll be talking with Dr. Jha over the White House about this pandemic and treatments available. But you mentioned the different variants that we're seeing from COVID-19. As a public health expert, is that unusual or is that unique to this pandemic, to COVID-19?
Well, I mean, viruses by their very nature multiply and mutate. And when those mutations give a virus the ability to spread easier or to evade the immune system, the immune protections that people have, you're going to see those new strains or variants take off and spread. And we've seen both of those things. We've seen new variants that have spread that have because they're more effective at going person to person. And we've seen variants that are spreading because they are good at getting around the immune system. One of the things that gives me hope, though, is that although we're seeing new variants and we're seeing people who are fully vaccinated, people who've had COVID before get infected again, we are still seeing significant degrees of protection from severe infection and death. So while COVID continues to spread and we don't know the impact in terms of long COVID and other things, we are still seeing some significant protection from existing vaccines, which gives us time while scientists are working to make new vaccines that are more effective against some of these newer variants.
And yet, as you mentioned just a moment ago, with these effective vaccines, we become weary of this pandemic and really a sense of complacency among many Americans.
Yeah, and I'll take complacency in two ways. One way that is not good is when people ignore some easy things they can do to reduce their risk and as well as the risk of other people. But the positive side is that we have seen an enormous toll in terms of mental health during this pandemic. I'm a pediatrician, I'm a parent. The stress on young people, the mental health toll in terms of anxiety and depression has been absolutely huge. And so you don't want people to be thinking about COVID, being on the edge of their seats, being highly stressed and anxious all the time. You need to find the balance there so that people are taking precautions where they're needed. People who are at greater risk are taking more precautions, and individuals who are at lower risk are getting about the joys of living their everyday lives.
And so as somebody who looks at this from a public policy standpoint, what can experts, what can lawmakers, what can we learn from this, and how do we apply those lessons for the future?
Well, I worry that we're not learning lessons and that we won't learn lessons. I ran emergency preparedness and response at CDC for 4 years. And in every crisis, we do an after action report. We come up with all the things that needed to change, and very little, if anything, would change going forward. And that's a cycle that you see with public health crises. It's what you see with government attention, where in the midst of a crisis, you can see the government come together and do incredible things. And we saw that throughout this pandemic, where Congress gave people resources to help protect their lives. Congress really rallied with big amounts of dollars. But now we're still in this crisis, and the administration can't get the resources to ensure that everybody in our country who needs to be tested can be, everybody who needs drugs and needs to see a healthcare provider can do so, that we are purchasing the vaccines we need for the next phase of this. And that's just a typical cycle. The attention of the American people, the attention of our elected representatives is short. And people don't like to stay in the midst of a crisis any longer than they're forced to. And we're seeing that play out now, even at a time where the crisis isn't over. When I think about please.
I was just going to mention that that's concerning because this is a pandemic that has affected every single American one way or the other, directly or indirectly, whether through health issues or through economic issues, through shutdowns. And then to hear that we're not heeding those lessons for the future is concerning.
Well, one of the biggest observations, and I don't call them lessons learned until they're actually learned, but one of the clear observations during this pandemic is, as you say, every community was hit hard, and not every community was hit to the same magnitude. Lower income communities, Black communities, Latino communities, Indigenous communities hit much harder than other communities, and it took a long time to catch up. There are many reasons for that. When you compare, especially early on this pandemic, how we did here in America compared to other wealthy nations. We're the only nation that doesn't ensure that every single person has high quality, comprehensive health insurance. We're the only nation that doesn't ensure that people have unemployment insurance and sick leave. These things really matter. during a pandemic. And we saw it early on when people were being forced to decide whether to go to work to be able to pay the rent and to put food on the table, or stay home if they thought they might be exposed, or stay home if they had to take care, of a loved one, with someone with a disability, of a child, of an elderly person. These are decisions people shouldn't have to make. And fairly early in the pandemic, Congress put money in people's pockets to make it a little bit easier for people to do the things they knew would help protect themselves, their families, and communities. But those dollars have gone away, and Congress has not stepped up. We haven't seen it as a moment in time to truly make that change. There's still 12 states that haven't expanded Medicaid. And we know that if you don't have health insurance, you're going to wait until you're pretty sick to go see a doctor. If you don't have a job that has sick leave, you're going to go to that job until you just can't anymore, because you know that if you don't go to that job, your family's not going to get the food that they need. And there were so many things during this pandemic that Congress did that gave me hope for the future. Things like taking away the eligibility requirements for school lunches so that every kid in every school in America got a free lunch. And we saw hunger among children go down. But that was something that Congress did not decide to make permanent. Why not make something like that permanent when you see the clear impact on children's lives? We, as a nation, we say how much we value children. But when you look at our policymaking, we don't hold that up. Just last year, the expanded child tax credit, it reduced child poverty by over 30%, and then it expired. And I was talking to a mom in the clinic where I see kids about that. She just talked about them as the government checks because she didn't know it as the expanded child tax credit. But for her, that check she received was the difference between staying in a motel with her daughter and sharing a bed, or having an apartment where her daughter had her own bed in her own room. And that's something we need to aspire to, and we could do as a nation if we kept the focus and truly learned the lessons from COVID.
So if you could, as somebody who understands public health, but also Washington, D.C. politics, if you could just take one aspect, I realize there are many layers, but one aspect of this inequity in terms of healthcare, especially among minorities and low-income families, what would it be?
Well, I think I would take on universal health care because that affects people across the board, disproportionately people of color, but rural communities, low-income communities. We see the impact, in states that haven't expanded Medicaid in terms of rural hospital closures, lack of access to care. But in America, this is a value that I think we can agree on across the political spectrum, that people's ability to get medical care shouldn't be dependent on their wealth. It shouldn't be dependent on whether they're working 3-4 minimum wage jobs to make ends meet. This is something that as a nation, we should provide to everyone in our country, and that's high quality, comprehensive health care. And we could do that.
And to make sure, as you said earlier, that the ER is not the primary care physician for those who wait so long that they're forced to go to an emergency room because they don't have a physician to see.
That's right. No one should have to make that choice. No one should have to make the choice between getting their cancer treatment or paying their rent, losing their house because they can't afford their house payments and their medical payments. This is something we can afford as a nation. And, the lessons of that in COVID are really clear. And there's risk to the entire population if individuals who have an infectious disease aren't getting the care they need early on. It means that they will be more likely to spread to others. So if you need a broader reason to do this, besides it's just the right thing to do, there are reasons in terms of the health of the entire community.
So let me conclude with your organization, the Robert Wood Johnson Foundation, which on so many levels has been on the front lines of all of this. Your short-term and long-term objectives over the next 6 to 12 months, and then perhaps beyond.
Yeah, so we are focused on building in America, helping to build what we call a culture of health, which is a recognition that health is about more than just access to high quality health care. It's what takes place in our communities, where people live and work, and where kids go to school and play, and where people gather to worship. All of those settings are critical to health. What we are looking at is really health equity. And that is, who has the opportunity for health and well-being and who does not? What are those barriers? Barriers due to systems and structures. We talk about health being about the choices we make, but it's so clear that the choices we make depend on the choices that we have. And due to things like racism and sexism and classism and the inability for people to make an honest buck for an honest day's work, people don't have the opportunity that they need to make those healthy choices. So we are focused on a number of things. We're focused on certain mindsets in America. One of those is deservingness. Who in our country deserves the opportunity for health and well-being? And then also shifting the focus from health being primarily about individual decisions to health being about the systems and structures in which we make those decisions. So looking to see how you can ensure that dollars are coming into communities that haven't been invested in, that families have the dollars and resources they need to raise healthy children, and that our public health system and our healthcare system is equitable and fair and meets the needs of every community. Those are our long-term objectives. But we talk about them as generational goals because we know that these are not quick fixes. In the short term, we're focused around what are some of the things that need to change right now. And just one example, last May, we convened a commission to look at public health data collection, because it was clear during the pandemic that most public health systems didn't have the data to be able to break things down by race, by ethnicity, by neighborhood, to see who was being hit the hardest, to see which neighborhoods were being hit the hardest. If you don't have that kind of information, you're not going to be able to target resources correctly. But that's just one example of looking at systems and structures. And I believe if public health is right in declaring racism a public health crisis, and hundreds of health departments have done that, we want to be there to help them figure out, well, what does that mean? What needs to change so that the next time there's a public health emergency, we don't see the same disparate impact, and so that every day in America isn't a crisis for so many millions of people.
But bottom line, with about 30 seconds left, you outlined some of the many challenges. Are we better prepared today than we were two and a half years ago, if and when the next pandemic strikes?
You know, Steve, I think in some respects we are, in terms of our ability to make drugs and vaccines. In terms of our systems and structures, I don't think we're much better off at all.
Dr. Richard Besser is the president and CEO of the Robert Wood Johnson Foundation. On behalf of the Bipartisan Policy Center, thank you for your time.
Thanks so much, Steve. It's a real pleasure.
Steve and Rich, thanks so much for that really informative conversation. And special thanks to the Robert Wood Johnson Foundation for their leadership during this pandemic. At this time, I'm really pleased to introduce Dr. Ashish Jha, the White House Coronavirus Response Coordinator. He was formerly the Dean of the Brown University School of Public Health. Ashish, great to have you here with us, and I'll now turn it over to you for your remarks on the state of the pandemic. Thank you.
You would think 2 years into a pandemic, I would start off by unmuting myself, but here we are. That may in fact be the state of the pandemic, folks. What I was saying was what an honor it was to be part of this event at the Bipartisan Policy Center. It's been such an important voice in this moment of a real crisis that our country's been going through. What I was gonna do is I was gonna take about 10 minutes 15 minutes and kind of lay out where we are in the pandemic and start in some ways with the long arc of this pandemic, where we have been, how I think this pandemic comes to an end, and then focus on the moment we are in currently, and how we think about it within the administration and how we continue to manage in a very active way this pandemic moving forward. So, you know, when the pandemic began 2 years ago, a little over 2 years ago, we had a novel virus and no population immunity. We had no treatments, very few in the way of diagnostic tests. And obviously that had a very large and a very negative effect on our society. And the initial response was a bumbling response. We did not ramp up our testing quickly. We did not communicate effectively with the American people how this virus spread, and that we were in for a challenging time. Over that time, and certainly in the last 18 months under this administration, the strategy has been much more focused on identifying tools that we think are going to be really critical for managing this pandemic, making them as widely available and easily accessible as possible, and trying to communicate to people how it is that one gets through a pandemic. Look, we've had pandemics throughout human history. We've gotten through every pandemic. They all come to an end. That's not the question. The question is, how do you get through a pandemic minimizing loss of life, minimizing severe illness, minimizing economic, social, political disruption? That's the question. And pandemics end ultimately when you essentially get to what I think of as kind of an immunologic détente with the virus. The virus is not going away. SARS-CoV-2 will be around forever. It's endemic in animals. It's widespread in humans. There is no zero COVID strategy that eliminates this virus from this planet. Not any time in my lifetime, certainly. And so we are going to be living with this virus forever. Now, living with this virus does not mean having ongoing disruption, does not necessarily mean that we have to tolerate any specific level of suffering and death. Those are really much more up to us. And ultimately, as I suggested, the pandemic, one way to think about a pandemic coming to an end is when it stops causing major surges, when it stops being so disruptive. When we get to what I mentioned was sort of this immunologic détente, where there is a lot of immunity in the population, the virus may evolve, but the virus does not continue to pose a substantial threat, and we can all go about managing it in a pretty straightforward way. That's not where we are right now. That's not where we are. Now, where we are is we have clearly made a massive amount of progress. If you think about where we were, again, I'm going to harken back to about 18 months ago when this administration came into office, to where we are. We've had hundreds of millions of Americans get vaccinated, a third of Americans get boosted, continuing to push on having more and more Americans have access to and be up to date in terms of vaccinations. Obviously, we've also seen a lot of people get infected over the last 2 years. That combination has meant we've built up a good amount of population immunity. And I think many people had hoped that that alone would bring this pandemic to an end. Unfortunately, it hasn't, because the virus continues to evolve very, very rapidly. And the virus's evolutionary pressure is very straightforward, which is the evolutionary pressure on the virus is to escape our immunity, and is to constantly find ways around the immunity that we have built up through vaccines, through boosting, and through prior infections. And that brings us in some ways to where we are right now with BA.5. So BA.5 has become dominant in the last week, 10 days. Many of you know BA.5 is a subvariant of Omicron. Depending on how you count it, it's probably the 4th or 5th subvariant that we've dealt with Omicron in the United States. And it is the most concerning so far. Eric Topol has described it as the most concerning version of this virus we've seen to date. What we know is it has a very high degree of immune evasiveness. And the way you deal with BA.5, and again, the way we're thinking about this, is making sure that the strategies and tools we have to keep people safe, to keep people out of the hospital, out of the ICU, obviously preventing deaths, that we really focus and double down on them. And let me walk through them at a high level. And then I think that will help inform how we think about the weeks and months ahead, and how we think about eventually finding a way out of this pandemic altogether. And then I'll stop and take questions. So the way you handle this right now, the way we have focused on handling this right now, is making sure that the vaccines we have, the prototype vaccines that were developed 2 years ago, they continue to function very well at preventing serious illness and death. And so one primary strategy is making sure that as many people are up to date with their vaccines and their kind of immunologic status as possible, so that it reduces the risk of getting infected. But really what it does is it reduces the risk that if people get an infection, that they'll get seriously ill, end up in the hospital or worse. That is strategy number one. Strategy number two is making sure that if people do get infected, that there is plenty of therapeutics available. Again, part of the goal is to reduce infections. I'll talk about that in a second. But a major part of the goal is to defang this virus. And the way you do it is through vaccines and therapeutics, right? And so the administration has put a lot of time and effort into, acquiring Paxlovid, which is an oral antiviral that is the best antiviral we have. Also have monoclonal antibodies. But the point is that anytime you deal with a new subvariant or a variant, you want to make sure that people are as immunologically ready to handle it as possible. And you want to make sure you have treatments available for people who are higher risk, who are going to have breakthroughs. And then the third part of our strategy is to do the things that we know are going to keep infection numbers low. And there are essentially, in my mind, three major strategies for keeping infections low that go beyond social distancing. Obviously, social distancing, keeping people apart is one way, but in general, I focus less on that these days because, let's be honest, 2.5 years of that, it's our social animals. We want to be spending time with each other. And so then the question is, how do you do that in a way that's safe? What we know is masking indoors makes a major difference. And we're doing a lot of work on making sure masking is widely available. We know that testing, especially regular testing, can keep infection numbers down. Super important if you're going into a gathering, if you're going to go to a wedding, you're going to go visit grandma, to make sure that you're tested beforehand. It reduces the risk of spreading it. And then last but certainly not least is a real concerted effort on improving indoor air quality. You know, when I think about in the history of public health, when we discovered that polluted water was killing people, we told people you might have to boil water for a while, but ultimately the long-term solution was sanitation, cleaning water so that now you can open up the tap and not worry about whether that water is safe to drink. We have got to have a similar strategy on indoor air quality. You should be able to walk into a building, walk into a room and not worry, is the room full of aerosols that have infectious particles in them? I think we can do all that. We certainly have the capability, we have the resources. So those are things that keep infections low. Vaccines and therapeutics keep people out of the hospital. Okay, how do we think about this in the weeks and months ahead? This virus has not stopped evolving. We are in the period of time where BA.5 is dominant. We can easily see cases rise. In South Africa, when BA.4 and BA.5 became dominant, you saw an increase in cases, bit of an increase in hospitalizations, but not a lot of increases in deaths. In Portugal, which is more vaccinated and more boosted than most European countries, higher rates than ours, what we saw was a huge rise in infections, large increase in hospitalizations, and a large increase in deaths. That's what we have to avoid. And so our strategy, certainly, as I said, vaccinations and therapeutics. And then the way I think about this is that we're going to get through whatever we see, whether it's a wave or just an small increase in cases. Then the next 6 to 8 weeks, that's going to be BA.5. Something else will follow. Maybe another subvariant, maybe a whole new variant. None of us know. And the strategy for the medium run, so short run we've talked about, the strategy for the medium run is to be ready, to have stockpiles of tests, to have stockpiles of personal protective equipment, to be updating our vaccines so they are as close to matching the virus as possible. That's what FDA has done with its recent authorization. I could talk about what I think is very bold moves by the FDA in this area. That is how we prepare for whatever Mother Nature throws at us this fall and winter. By the way, that job has become much, much harder, and you heard Rich Besser talk about this, because Congress has decided that they don't want to fund that kind of effort. And so we are now trying to put together resources to make sure we have at least some of the new vaccines, that we have at least some tests going into the fall. We're not going to have enough. So that's the kind of medium-term strategy. And then the long-term strategy of getting out of this pandemic is we need a whole new generation of vaccines. We need pan-sarbecovirus vaccines, basically pan-beta coronavirus vaccines that are variant resistant. The science on that is actually quite good. It's very promising. We need mucosal vaccines that reduce infections and spread. And we need a whole new generation of therapeutics. All of that is how we bring this pandemic to an end and really create that détente that I talked about. But that will require investments. It will require investments from Congress. That is not something that the markets will do those things, but it will take 3 to 5 years. We can substantially accelerate that with what I think are relatively modest investments that really bring this pandemic under much, much better control and then really end the emergency phase. Not there yet. So as an administration, I'll just finish off by saying we've been thinking about each of these phases. What do we do to manage the moment? How do we think about that medium term of the weeks and months ahead of us and making sure we're as ready as possible and trying to bring Congress along? And then we've been thinking about the long game and how do we bring this pandemic to its heels and really get to a point where this virus is no more than a nuisance. I think science has proven to us in the last 2 years that it can deliver on those things. But we need to make sure that Congress supports it and we execute on that. So let me finish with that and say, Anand, thank you for having me here. Always a delight to be part of any BPC event, and looking forward to questions.
Thanks, Dr. Jha, for those remarks. It was very comprehensive. Terrific. Thank you. So we have a couple of questions from the audience. I'll start off with two, and then Ashish, you can take whichever one you'd like. The first is on data, the second on kids. The first question from the audience: what are the data or metrics the administration is following to understand the impact of the pandemic moving forward? So what are the numbers that you're tracking? And then two, with lower immunization rates in children, how concerned should we be about other vaccine preventable disease outbreaks? I'm assuming the question there relates to the spillover effect of reduced immunization rates, but you may want to talk about just how we're doing in terms of vaccinating kids, COVID. Yeah.
Okay, so let's talk about data and then let's talk about kids. And we talk about data on kids, but no, let's start with data. Throughout the whole pandemic, I think back to the early days of April, May, June of 2020. There was never a single data source you could go to or a single data point and know that you were looking at the pandemic in all of its complexities. We just haven't had that. Partly because we've had data challenges in our country and we've made a lot of progress there, but partly because there isn't a single data point. So if fast forward to today, where we have learned a lot about this pandemic, when I think about what do I look at every day to get a sense of the state of the pandemic in America? Do I look at cases? Sure. I also know cases are substantially underreported because a lot of people do testing at home. We know a lot of people don't do testing at all. We've always missed a large chunk of cases or a large chunk of infections. And that problem is probably worse now because of home tests. And by the way, let me be very clear. I'm a huge believer and fan of home tests. It's just that it leads to more underreporting. So cases are important, but we know that that's not enough. Obviously, care a lot about hospitalizations and deaths, and those are very, very important metrics. They tend to lag. Hospitalizations by about a week, deaths by several weeks. Actually, because of the progress we've made on therapeutics, we're seeing that lag with deaths even further stretch out. That's a good thing from a public health and clinical point of view, but a bad thing if you're trying to use deaths as a marker for understanding where the pandemic is going. There are thankfully other sources of data that we have learned about. One of my favorites, and it's a little gross, but I'll say it, is wastewater. Wastewater data is incredibly useful. It's very predictive, it's live time, it doesn't suffer from reporting bias. For those of you who are not deeply familiar with it, it turns out that SARS-CoV-2, this virus that causes COVID, also passes through our GI tract, ends up in the wastewater, and you can actually quantify the amount of virus in a community, and that gives you a very, very good feel for how much infection there is in a community. There are certain places in America that are doing a fabulous job of that, other places that have not quite set that up. We've got to make wastewater one of our major sentinel sources of surveillance. It's a very good way of tracking not just this, but other diseases as well. Okay, so that's kind of how I've thought about data, that comprehensive approach that looks at multiple sources and triangulates. You know, in terms of children, 2 points I want to quickly make. One is that there has been so much misinformation about COVID in kids, so much minimization. And one of the classic things that people say, which sounds really smart, but it turns out to be not actually that interesting of an insight, is that kids are at lower risk than adults, or kids are at lower risk than the elderly for COVID complications. Guess what? That's true for almost every disease, right? Leukemia, kids are at lower risk of dying from leukemia if they get it than the elderly. But we don't go around saying, well, childhood leukemia is no big deal because they're less likely to die than the elderly. That's the wrong way to think about this. And pediatricians actually understand this intuitively because they take care of children. The question on COVID and kids is not what's the risk in kids versus the elderly. The question is, how does the risk of COVID in kids compare to other risks that children face? Other diseases, other infectious and non-infectious diseases. When you use that as a metric, it turns out COVID is actually quite a substantial source of morbidity and even mortality in children compared to other childhood illnesses. So that's point number one. Point number two is that these vaccines are exquisitely safe and highly effective at preventing serious complications in children. So in that context, it's a no-brainer in my mind that kids should be getting vaccinated. The problem has been that there has been so much, again, misinformation on children and vaccines and COVID that it is unfortunately, Anna, that I'm worried about this spilling into other areas where you now see prominent people questioning vaccines all around and saying, well, you know, maybe vaccines are not so important. And this is a problem because it's a side effect of all the success. We don't see all the suffering that vaccines have eliminated. And now it's very easy for anti-vax people to talk about those diseases maybe not so bad because nobody has seen them because vaccines have been effective. So I'm worried we're heading towards a time period where we're going to see a resurgence of vaccine preventable illnesses. We've got to do everything possible to avoid that.
Great. And one final question is very briefly, you talk to policymakers on both sides of the aisle. What is your bipartisan message, I guess, from a bipartisan perspective, in order to ensure that policymakers make the right decisions so that we can combat the pandemic and get through that? What's that bipartisan message that you usually take to folks on both sides of the aisle?
Yeah. You know, what I remind folks both on the Democratic and Republican side is we have robust debates and discussions about the proper role of government, roles of regulation, roles of free enterprise. Those are important things that Americans debate on an ongoing basis. In a crisis like this, in a pandemic, what this pandemic has shown us is that if we're going to get ourselves out of it, we actually require very deep cooperation between the private sector and government. If you think about how quickly these vaccines were developed, could that possibly have happened without government? Absolutely not. Could it possibly happen without the ingenuity of the private sector? Absolutely not. And so what this pandemic has taught us is that at critical moments, it's actually the cooperation of government and private sector working together for common purpose that moves us out of the problems we find ourselves in. And so then comes two messages. One is we got to keep doing that because we're not done with this pandemic. And second, we've got to use that as a model for solving other public health, healthcare, and non-health issues, because it turns out that kind of cooperation isn't just good in a pandemic. It's probably quite useful in lots of other areas as well.
That's great. Well, Ashish, thank you, Dr. Jha, for joining us today. Thanks for your public service and the administration's efforts combating the pandemic. Looking forward to staying in touch.
Thank you.
And now I'm very pleased to be joined in a discussion with Dr. Natasha Bagdasarian, who is the Chief Medical Executive at the Michigan Department of Health and Human Services, and Dr. Kathleen Toomey, Commissioner and State Health Officer at the Georgia Department of Public Health. Natasha, Kathleen, thanks so much for being here. I think we've heard a lot in the last half hour or so from a high level and a federal perspective about the state of the pandemic, and I think we're eager to learn from you about what you're seeing at the state and local level. And perhaps maybe the place to start is to talk a little bit about your current priorities with respect to responding to the pandemic in your state. And Natasha, if you want to begin, and then Kathleen will move to you. Thank you.
Thanks so much for having me on today. I think that every day when I wake up in the morning, one of the first things I do is take a look at our COVID numbers, not just in the state, but around the country. And it really illustrates, your question really illustrates how there is no one size fits all answer. And every state is really facing their own obstacles and specific set of challenges. So while much of the country is seeing an uptick in cases, likely due to BA.5, we in Michigan in the north are actually in a fairly stable place. Our case rates have not increased to a significant degree as yet, and our hospitalizations have also not increased. So we are preparing for a surge. And that really means looking at our tools, looking at vaccines and therapeutics. And when I think about vaccines and how we're really approaching this issue, we're really looking at our disparities. That is our predominant issue right now, is disparities in vaccine uptake. And what we're seeing is that certain communities of color, have much lower vaccine uptake than others. We're seeing that younger age groups have much lower vaccine uptake. And we're also seeing that vaccine hesitancy, one of the only ways to combat this in the long term is by incorporating COVID vaccination into routine clinical care rather than keeping COVID care as something separate and different. And the other part of this, Anand, if I could add, is we're also trying to better understand some of our disparities. One of the challenges that we have faced throughout the pandemic is gathering data and whether the federal data that we're gathering meets the needs of our state, for example. One of the things that we see here in Michigan is we have a fairly sizable Arab American community. And when we look at our vaccine data, we don't have data down to that degree that really allows us to see how some of our specific immigrant, migrant populations, some of our very specific vulnerable populations in Michigan, how they're doing in terms of vaccine uptake and some of their health outcomes. So we're really focusing on disparities, minimizing those disparities, understanding those disparities, and making sure that we're rolling out our tools in an equitable way in preparation for the next surge, which hasn't hit us yet. And I think that, again, this really illustrates how there are geographic and seasonal differences that could be affecting different parts of the country.
Thank you. And Kathleen, I guess as a southern state, Georgia may be in a slightly different position right now.
Indeed, we are. In fact, there is so much that was said both by Dr. Besser and Dr. Jha. It really resonated with what we are dealing with and how we've had to deal with. Basically, our priorities are no different than they were at the beginning of the pandemic, trying to get the data to understand where we are as a state, and where we are is seeing an uptick of BA5, although because of quite a bit of home testing, we aren't seeing the numbers within our surveillance system, but we are certainly seeing it in community cases, but also just testing and having availability of testing. Clearly, vaccinations are so critical, and treatment, and having the availability of very good treatment, antivirals as well as monoclonal antibodies. Now, what was perhaps different than Michigan is our vaccine uptake is equally, we have total equity in our vaccine uptake. That is, we have very low vaccine uptake among all racial and ethnic groups. And we have, but you can make that generalization just by looking at the total state data, because our state is so diverse. Atlanta, very urban center, very progressive, is quite different than parts of rural Georgia, is very different than North Georgia, very different than South Georgia. And so as we have tried to approach basically moving forward in the pandemic, you have to take very different messaging to try to encourage increased vaccination rates, which are higher, not surprisingly, in urban areas, in urban Atlanta and Savannah, for example, than they are in a lot of our rural areas. But the other thing that I have to say is that COVID was kind of a solo act for public health initially. We realized, just as Dr. Jha was saying, that working with the business community, working with the private sector, working with a broader healthcare system, which public health, frankly, in Georgia didn't do prior to this, was the way we were going to address COVID, as well as other health issues now and in the future. We had very little infrastructure. Our surveillance system crashed almost immediately, and had difficult time catching up. Our immunization registry crashed within a very short time. We are working on that infrastructure. It's not there yet where it needs to be. So these are all the kinds of things that we are dealing with that in some ways are repeats of what we saw initially, but trying to, even as we're doing this, also trying to go back to core public health issues. That is, childhood immunizations, women's health, family planning, maternal mortality issues that are a big priority for us here in Georgia. So we can no longer work in that silo of COVID as we did for almost 2.5 years, and now have to be able to multitask in public health with a workforce that's exhausted. I think, as Rich Besser talked about, mental health issues. We have mental health issues within the public health community, PTSD, literally, among staff. And so these are all the things we have to simultaneously begin to address, with a lot of challenges, and looking at really for federal, both resources, but also leadership to help us get there.
This discussion about the public health infrastructure actually relates to a question that just came from the audience about the readiness of our public health infrastructure, including workforce, for the next emergency. I guess to both of you, how can the federal government be a better partner to your states as we think about getting through this pandemic, but also building up this public health infrastructure that we know that we've underinvested in as a nation and we need to build up? Natasha, please feel free.
Maybe I can start with that. I do think that we can really perhaps use COVID-19 as an opportunity and really see this as something that has brought to light some of the issues with our public health system. We've been talking at our state level a lot about how to use COVID-19 as an opportunity to build back a better public health system. And we've identified two major pillars of this. The first is strengthening public trust. We really saw through this pandemic that public trust and our relationship with the public had been eroded by both the politics of the day as well as by previous incidents. Here in Michigan, we grappled with the Flint water crisis in the last few years. So there have been incidents and there has been a climate that has eroded public trust. And how do we use COVID-19 as an opportunity to build that back? And the other part of that is of course, public health infrastructure. Public health has long been underfunded and ignored and neglected. And now is the time where we have really seen and we really highlighted how our data systems need to be strengthened and how our workforce has been decimated by this pandemic. Here in our state, as well as in states, other states around the country, we've seen public health officials being threatened and fired, forced out of their jobs. And I think that it has eroded morale across public health. And so I think focusing on those two components, strengthening public trust and improving public health infrastructure, I think that's really where we need help moving forward. But if I could go back just to the specifics of COVID as well, I do want to say that we have needs moving into the next few months. We've got our long-term needs that I mentioned and how to strengthen public health, but we also have our short-term needs. I talked about preparing here for future surges. We are expecting surges this fall, and we're expecting probably a bigger surge this winter, depending on what variants are circulating at that time. And we are constrained by a lack of insight and a lack of information about what our tools will look like, what the availability of over-the-counter tests will look like. Will we be able to purchase monoclonal antibodies when funding runs out for that? So part of it, I think, is supplying us with the tools we need for our long-term needs, but then also those short-term needs. And then the other part of this, Anand, if I could just add, is I think that one thing that is very much needed right now is an overarching strategy, is an overarching strategic framework for the country. I talked a lot about how in the beginning that there's no one size fits all, that what's happening in Georgia is very different than what's happening in Michigan, where we're not experiencing an uptick in BA5 yet. But I do think that if we have an overarching strategic framework, each state could then adapt that and tweak it as needed. And we don't have that right now. And that goes back to our communication with the public. If we're not all saying the same things and we're not speaking with the same terms and using the same sort of strategic framework, I think it becomes more difficult for the public to understand where we're heading and what we're talking about at the state level.
Well said, Kathleen.
And I have so much to say, you're going to have to pull the hook and pull me off of here, because I mean, there's so much that the federal government helped us with that was just absolutely critical. Initially with the testing, initially helping us to understand the data, and also the vaccination is a miracle, really a medical miracle. What has happened to be able to create these safe and effective vaccinations. We're a little different than any other state because CDC is in my state. I am the most important health officer in the nation because I keep CDC healthy. And the problem, of course, is that we were not always saying the same things. And so getting back to that concordance, the things that CDC and the broader federal government helped us with was everything from the vaccinations clearly, but also the testing, the availability of testing, helping us to understand, but also to proactively helping us to understand the data, because they have an ability, or we hope there's the ability to see forward in a way that we can't, as we're kind of in our own, looking through our own tunnel of our own state or our own local area. And we really need that. I think the other thing that probably wasn't recognized were all the federal grants that we got that allowed us so much, including workforce. That workforce grant was absolutely a critical piece that allowed us to expand in so many areas of public health and that COVID work. So everything from nursing to epidemiologists to others. What I'm seeing, and I hate to say this because I've been around in public health too long. I think I mentioned to you, I was here during 9/11 at the same position. Now I'm here during the pandemic, and the same things happened. A lot of money poured into public health, but it wasn't sustained. And if that happens, if we continue to see a short-term federal input into public health, but 2 years later, that workforce money is gone, we'll be right back where we started from. And we'll have lost those potential gains. And there has to be sustainability, not just, frankly, not just in the federal infrastructure support, but we need to figure out a way collectively in this nation to get support for public health from state and local areas as well. Because I don't think, unless we want to federalize the public health system, which I don't think there's at least I don't think in Georgia there's an aptitude to do that. We need to figure out that way, whether it's the trust issue or recognizing the value that this brings way beyond just the short-term, what will be viewed as a short-term pandemic. I think, but I think you could cue off of all of those and talk for another 30 minutes.
I'd like to actually cue off of that point about trust and communication and ask both of you, Kathleen, maybe we could start with you on this one, how you're engaging, I guess, a pandemic weary public and population, and how are you able to combat some of the misinformation, disinformation that we've seen? There's a question here from the audience about high quality masks and the pushback against wearing masks. What can we do to encourage mask wearing and vaccines and some of these tools that we've heard about and we know about to ensure that people can stay healthy?
I think we have several communication campaigns underway to try to talk about getting back to where we were, getting back to Georgia as we know it, kind of addressing the fact that we recognize that people are tired of this, but also showing scenes of life as we once knew it. And this is the way to do that is with vaccinations and boosters, and as well as reminding people about the importance of childhood immunizations, including the COVID vaccine. I think the way I have done it from the beginning is to try to model the behavior. But again, there's very different political attitudes in Georgia than perhaps there is in other states. And so that it's very, very difficult to mandate, wearing masks. But I have consistently worn a mask. I've consistently worn a mask everywhere I've gone. And so I think that all of us in public health have been modeling the behavior that we hope will be continued and reflected back in the public. But I think the other issue is always going to be social media. I have never managed any kind of health crisis in the age of social media where they are 20 steps ahead of us and much better to articulate issues that may not be accurate, but they're just faster at getting that information out. And so it goes back to that whole situation of communication. How can we get those public health messages out in a more convincing way, in a quicker way, in a more agile way, that we don't find ourselves always playing catch up. And I think I'm looking to CDC for that as well. Again, we share the same media market, and yet I would say that Dr. Walensky and I are both playing catch up with the communication piece.
Natasha?
I think it's difficult to engage a public now more than 2 years into this pandemic with the same message. So if the message is always be on high alert, We want you to be at your maximum degree of wariness and caution. I think that's a difficult message to communicate now over 2 years into the pandemic. One of the things that we have done here in Michigan, which is a little bit different, is we've talked about the COVID response as a cycle. And we've talked about response, recovery, and readiness. And this being a cycle and being and needing different sorts of responses at each phase in the cycle. So we were in response when we had our Omicron surge. We were all hands on deck, getting all of those tests out into folks' hands, getting all of our therapeutics out there. We're in recovery right now. And I think it's just as important to communicate when things are terribly high risk as well as slightly less risky. And so we're trying to find a balance in being able to communicate both dialing up our mitigation measures as well as dialing down. And so in recovery, that's our signal that this is a time where we can maybe get back to some of those activities that people have missed out on over the last 2 years. It doesn't mean we just throw all of our mitigation strategies out of the window, but I think it's important to communicate to people that it's not always red alert, because I think that message starts to get old after some time. We, again, in this period of recovery, it doesn't mean that we're forgetting about COVID. We're working on those disparities. I think that's the biggest issue here in our state. We're working on why some of our 5 to 11-year-old groups in some parts of the state have vaccine uptake that's closer to 60%, and some groups have vaccine uptake that's closer to 10%. That's not a good way to move forward with disparities like that. And so as we're in recovery, we're still working on some of these messages. We're really focusing on using trusted messengers. So I may not always be the best messenger for every group across the state. I think people like to see folks who look like them and sound like them and people that they know in their communities speaking about vaccines and other public health messages. And so we've been working with faith-based leaders and other community leaders and people who are well known to different communities so that they can communicate those messages out. But I do, Anand, think it's important to talk about dialing up and dialing down. And that's part of our overarching framework. That perhaps we're not always in red alert. We should be able to talk about these different gradations so that this sense of COVID fatigue is perhaps not as great now 2 years into this.
Very important message. Thank you. We are quickly running out of time. I think we'll try to get in one more question and again, a brief response. And the question is, have either Michigan or Georgia addressed the indoor air quality, as Dr. Jha emphasizes, a mid to long-term approach to minimize transmission? So obviously a lot of discussion that we usually have on vaccines, treatments, testing, and masks, but this sort of fifth pillar of indoor air quality becoming increasingly important as our understanding of that. Anything either of you want to mention on indoor air quality and what may be occurring in the state to promote that?
I'm happy to weigh in quickly. In Michigan, we really felt that indoor air quality in schools was something that was, something that needed to be improved long-term for the health of children, not just from COVID, but other respiratory viruses, asthma, other respiratory pathogens. So we had engineers and other folks consulting with schools, but part of the issue is sustainability. As Dr. Toomey mentioned, when funding comes in a non-sustainable way, it's really difficult to make changes for the long term. So money came into schools initially for the COVID response, but these were schools that really needed that funding initially for other things. And so in order to make those types of systematic and long-term sustainable changes, I think we need long-term sustainable funding sources.
Dr. Toomey, Kathleen?
And I would say very quickly that it's schools as well. It hasn't been consistent across the state, but where it's been done effectively in some of the schools where there's a proactive approach to the pandemic. And I think this is something we need to be working on as a statewide, not just in the school setting, but in other public and private setting and working with the private sector.
Great. Well, I want to thank both of you, Dr. Bagdasarian and Dr. Toomey, for your participation today and your leadership. We appreciate you being with us. And that concludes today's event. We hope you've enjoyed today's discussion. It's clear that the continued pandemic response requires a science-based and bipartisan response at all levels of government. Please be on the lookout for future BPC health events. And until then, thanks again, and please take care. Thank you.
Thanks so much for having us.
Thank you.